meeting was opened up to the public, and we will be recording it today so that we can post it on our website. So just so that you know, so that people that weren't able to attend will be able to view it after. Just let you know ahead. And I'm going to turn it over to Olivia Alford to introduce herself.
Good afternoon, everyone. Olivia Alford, she, her pronouns. I'm the Director of Delivery System Reform within MaineCare. And Heather, if you have too much audio issues, you're welcome to come camp out in here during this if you need to transition at some point.
Thank you.
I'll pass it to Kristen.
Thanks, Olivia. Hi, everyone. I'm Kristen Merrill. I am the State Plan and Policy Development Manager for the Office of MaineCare Services and currently the Acting Policy Director. I will pass it over to Heather.
Everyone, I'm Heather Bingalis. I am the policy writer for the Long-Term Supports and Services Unit in the Policy Division. I work under Tom Leet, who is out, so I am filling in for him while he is out on paternity leave. I'll turn it to Natalia.
Hey, thank you. My name is Natalia Hall, and I'm the Associate Vice President of Palliative Care at Northern Light Health. And I'll pass it to my dyad partner, Dr. Little.
Hi, I'm Vanessa Little. I'm Natalia's partner, Medical Director of Palliative Care at Northern Light.
And I'll turn it over to Amanda Lee to introduce herself.
Hi, I'm Amanda Lee. I'm the rate setting coordinator at MaineCare.
Thank you, Amanda. And Lauren?
Yeah, hi, I'm Lauren Mikalakis. I am a program consultant with the Office of Aging and Disability Services. I'll turn it over to Candace.
Hey everyone, Candace Powell, Executive Director of Maine Hospice Council and Center for End of Life Care. Thank you.
Jane?
Jane Conrad, and I'm a patient and family caregiver advocate in the Mid-Coast area.
And Vance, I'll just call in order I see you on my screen.
Hi, everyone. I'm Vance Brown. I'm the Chief Medical Officer for Androscoggin.
Natalia? You already introduced yourself. I apologize. Becca?
Hey guys, Becca Hutchinson, Senior Medical Director for Palliative Care for Maine Health Medical Group.
Marianne?
Hi there, Marianne LaFollette. I am Associate Planning Manager with Maine Health, actually working with Becca, who just introduced herself. So,
Karen?
Good afternoon, Karen Mason, Associate Director at the Office of Aging and Disability Services, and I oversee the Healthy Aging and Long-Term Supports and Services programs.
And Leanne?
Hi there, Leanne Howard, Vice President, Clinical Operations at Northern Light Home Care and Hospice.
And Colleen?
Hi, good afternoon. Colleen Hilton. I serve as the Senior Vice President for Continuum of Care for Northern Light Health, which encompasses home care, hospice, palliative care, and our long-term care facilities.
And Gail?
I'm sorry, did you say Gail?
Yes.
Sorry. Gail Jewett, Vice President of Practice Operations for Palliative Care, Maine Health. Thank you.
Thank you. Brenda?
Hi there, Brenda Farnham. I am the Associate Vice President for Oncology Services here at the Lafayette Family Cancer Institute for Northern Light Health, and Acting Practice Manager for Palliative Care.
Thank you. Robert?
Hi, I'm Robert Donor. I'm the Medical Director for Maine General Palliative Care and Hospice.
Thank you. Trudy?
Trudy Richmond, I'm a quality RN at Sebastopol Valley Hospital under Northern Light Health.
Thank you. And Rose? if you're having trouble reaching the mute button, we'll come back to you, Rose. Heather Sinclair.
Hi, I'm Heather Sinclair. I'm the social worker at MDI Hospital for the Palliative Care Program.
Thank you. And Lisa Letourneau. Can't hear you, Lisa. We can come back to you. Kyra?
Hi, Kira Mancini, Director of Practice Operations, Palliative Care, Maine Health.
Thank you. Lisa, are you able to introduce yourself? Well, feel free to jump in as we get started and introduce yourself, Lisa, if you're able to connect. Well, welcome everyone. I want to let you know that we will be sending out a staffing survey after this meeting. And we'd like to ask you if you are a healthcare organization that are interested in completing the staffing survey to help inform this project, to please share your name of your organization, the contact person for your organization, and the email in chat. Many of you have been part of this project since it got started, and some of you have been invited or came in response to the public e-message, and we welcome you, and we're excited about having your participation in this project. This staffing survey will just help inform our next steps in developing this model, and we're grateful for your participation. So feel free to put that in chat, and we will be recording those to send them out after the meeting. I'm going to share my screen. Apologize. My screen jumped and covered you up so I couldn't see you anymore. I'll try again.
It looks good for us.
Is it sharing the full screen or is it the half screen?
Nope, it's the full screen.
Oh, okay. Interesting. It's showing the other one on for me. Thank you for letting me know. All right, now I can see everyone. Lisa, were you able to connect with audio? Did you want to introduce yourself?
Sure. Hi, Lisa Letourneau, Maine DHHS Senior Advisor in the Commissioner's Office. Thanks.
Thank you. All right. So as our agenda today, we've gone through our welcomes, and we're going to do a project update, review the national guidelines, build, our project building this palliative care team services model, and then staffing survey guidelines, and then our next steps. If you have any questions while we're going through this, feel free to put them in the chat or raise your hand and we will call on you. So what is palliative care? Public Law Chapter 401, Section 1726 defines palliative care as patient-centered and family-focused medical care that optimizes quality of life by anticipating, preventing, and treating suffering caused by a medical illness or a physical injury or condition that substantially affects a patient's quality of life, including but not limited to addressing their physical, really their whole person needs, physical, emotional, social, and spiritual needs, to facilitate patient autonomy and choice of care, and providing access to information, discussing the patient's goals for treatment and treatment options, including, when appropriate, hospice care, and managing pain and symptoms comprehensively. This definition has guided our work in developing a draft model of palliative care team services that will support the a comprehensive palliative care services to meet these goals. So our progress to date, we've had 7 stakeholder sessions. We've met with the National Academy for State Health Policy, NASHP, and other Medicaid, state Medicaid agencies developing palliative care benefits, attended the inaugural statewide palliative care conference. We've been engaging with the NASHP State Policy Institute to improve care for people with serious illness, to refine the draft model and the eligibility criteria with expert supports. We completed a very large data analysis request with Maine Health Data Organization to inform eligibility and cost rate analysis work that will begin later in this project. And we have developed a draft, which we'll be sharing with you in the staffing survey of a palliative care team services model and staffing survey that to be completed in the next month to help us inform our next steps with the project. So what is the NASHP State Policy Institute that we've been part of? They've provided us really invaluable support in this. We've had advice from national experts in states who have received CMS approval. They are providing data analytics support to better understand MaineCare's eligible population with serious illness. They've helped us refine the draft model to align with palliative care best practices, effective eligibility criteria, and discharge criteria. They've helped us understand utilization potential for Maine, and we've, the Maine team that is part of this effort includes a representative from ODES, from hospice, and from medical, from Northern Light Health, Maine Hospice Alliance, and from ODES, Office of Aging and Disability, to better support this model, this development. The LD 1064 that instructed us to provide this, to work on this model, instructed us to look at national standards, and they cited the clinical guidelines for quality palliative care developed as part of the National Consensus Project with the National Coalition for Hospice and Palliative Care, which really describes a model that is team-based and it's whole person focused, is culturally and linguistically appropriate. It's interdisciplinary team with palliative care certification. It includes care management and coordination, plan of care, comprehensive transitional care, patient and family-centered care, planning, education and supports, advanced care planning, and including the serious illness conversation. And so we began this work really looking at this model to make sure that the model we're building is aligned with these best practices. So what is serious illness? The working definition that we've been using to guide our work comes from research done by Kelly. I've left a link here for identifying the population with serious illness, the denominator challenge from the Journal of Palliative Medicine. They done a lot of work in helping identify prospectively what patients have serious illness and need palliative care services. And so the definition that we've adopted for this work to guide us is serious illness is a health condition or multimorbidity that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life or excessively strains their caregivers. And so building this model, we really were looking at this, where do palliative care services stand in the continuum of care? MaineCare currently has a model for chronic condition care management for individuals with chronic conditions and evidence of fragmented or care management needs. But where does palliative care fall? So palliative care really is a very similar model, but for individuals with higher needs and a larger team and more intensive services. And so we kind of started out with that perspective and then started working through the elements. And so for a model that is team-based, we often consider an alternative payment model, which in this case allows us to provide inclusive reimbursement for a team of professionals and is reimbursed sometimes as a per member per month. This reduces administrative burden. It supports fiscal service and fiscal sustainability. It includes quality measures to support a patient-centered value-based model. And it requires core standards to ensure provider capacity to deliver services as they're intended. And that just allows there to be, so if the payment is once a month, there's that accountability for that quality of care to meet the needs of patients who have serious illness. Pausing for any questions? Okay, I see some chats. Okay. All right, so what are our core standards? There's 11 categories of core standards. In our slides here today, these will be described on a high level. The staffing survey will include a more detailed description of all of these elements that we reviewed today. And so you will have that after the meeting. It will be sent out, and that will allow you to review in more detail. The categories of core standards are person-centered care, demonstrated leadership, team-based approach to care, population risk stratification and management, enhanced access, integrated care management and capacity, integrated care management capacity and processes, behavioral and physical health integration, inclusion of patients and families, connection to community resources and social support services, and commitment to reducing waste, unnecessary healthcare spending, and improving cost-effective use of healthcare services. Integration of health information technology. And regarding unnecessary healthcare spending, that really gets into supporting patient preferences around care. In the individuals with serious illness will have higher utilization rates because they need treatment, but oftentimes their preferences are not necessarily established in a plan of care to avoid, and they don't necessarily have the supports they need, both clinically and care management wise, to avoid utilization that's unhelpful, that is avoidable. And so the palliative care team includes a manager, medical director, the clinical leader, behavioral health specialist, child life specialist, behavioral health professional, child life specialist, nurse care manager, pharmacist, and a chaplain, clinical chaplain. In the model that we've been developing, we've identified that it's possible that a medical director and clinical leader could be the same individual as long as they meet the requirements of both roles. And a behavioral health professional and child life specialist could also be the same person as long as they meet the requirements of both roles. And also noting that as this model has been drafted, the members of the team would not be required to be full-time employees to a full-time equivalent of the team, but could be contracted for the portion of the panel that is receiving palliative care services. And I'll pause for questions. It's a quiet group today. Feel free to put your hand up if you have any questions. So there's service categories included in this model. One of those are is comprehensive care management. This includes the comprehensive social assessment, which is identified in the national guidelines. The parts of that are including patient and family history, physical and mental health, substance use, functional and/or developmental status, needs regarding pain management, transitional care, in-home services and supports, health-related social needs, medication inventory and history, social supports, advanced care planning and treatment preferences, and spiritual and religious preferences, and leisure and recreational preferences. Really getting to know the whole person, their current state, and their needs regarding their serious illness, but also understanding any barriers to care that are occurring for the patient in any of the areas of their life, whether it be their functional status, health-related social needs, to help address those through the other categories of services to help them meet goals of a plan of care, which is the next part of care management. Is a plan of care that is patient-centered, is developed with their family, guardians, caregivers, and members of the patient's clinical care team according to the consent and as appropriate. Documented goals of care, serious illness conversation, and it's reviewed at minimum every 30 days in the palliative care team's weekly panel reviews. And additional services under care management would include weekly team panel review meetings, participation in multidisciplinary team meetings. This means if a specialist needs you to meet with them to help them understand the patient's treatment preferences regarding their plan of care, that participating in those meetings, medication review and reconciliation, and nurse care management services, including one in-home assessment annually with telehealth connection to a physician, physician assistant, or APRN, to the clinical lead or otherwise qualified. And the biopsychosocial assessment would be updated at minimum every 90 days. I'll pause if there's any questions. I'm either putting you to sleep or I'm answering all your questions with the slides.
Hey, Heather,
Yes.
Vance Brown. Can you say a little bit more about the initial comprehensive assessment, in-home assessment? I'm not sure if I'm quite following what that model is and whether it can be done virtually. Who would anticipate the care team members who would be part of that type of assessment?
Yeah, the feedback that we've received is that that as part of the model, as part of the team services, that really understanding a person, individual's needs when they have serious illness, that one assessment done in the home is incredibly important to understand both what they're experiencing medically, but also their informal supports, their need for DME maybe in the home to help be more mobile or accessible, fall risks, those functional issues. And so that's why at this point, we've included that in the model. And so the intent is that with the initial comprehensive assessment, that would be completed at least in part in the home. And the team members that we would anticipate delivering that would be like an RN with telehealth connection to a palliative care provider, whether that be a physician assistant, or APRN. And so that would mean that if you would think of it as the nurse rooming the patient at their own home and then facilitating that connection to the provider. One of these a year would be included as part of the model as this, in this draft. So in other words, if the patient is a new patient and they've had that initial assessment, comprehensive biopsychosocial assessment in the home, then that would meet the need for that for the year. And so it just have to be updated. That's how we've drafted it now, just because there's been a lot of research that's come out around the benefits of that in-home assessment. Does that answer the question? Any other follow-up questions? Okay, thank you. So care coordination is the next category. And that is to facilitate and support access to high quality whole person services, including medical services, behavioral health services, long-term services and support, community-based organization resources and services, hospice services, medication review, durable medical equipment and supplies, and anything else, any other services identified as needed by the patient's assessment and in their plan of care. Care coordination for pediatric patients includes active engagement with the parents, guardians, and or caregivers. And care coordination includes advanced care planning, coordination, and communication. So, that's going to be helping ensure that the patient's entire care team within, both within the palliative care team, but also the larger clinical team understands the patient's preferences for treatment, and their advanced care planning documents are available. And then 24/7 clinician availability by phone for patient triage and support. So to help patients when they feel like they're having an emergency, they're having symptom exacerbation and they're not sure, is this a time I need to go to the emergency room or not, having that availability to reach out to a clinical provider and get that guidance. We've received a lot of feedback that is a really important part of this model. And so I'll pause there. Any questions or thoughts?
Heather, I have a question.
Go ahead,
It's Jane. You mentioned care coordination for pediatric patients, but what about care coordination with caregivers for adults?
Can you give a little more example of what you mean, so I make sure I understand?
I'm just eager to see involvement of caregivers of adults in care coordination to the extent that you can do that. And because you just addressed pediatric patients, I wasn't clear on what you expect for adults.
So do you mean care coordination for the services to caregivers or by caregivers?
So that the caregiver understands the care the patient will be receiving.
Yes, actually, we're going to be addressing that in an upcoming slide. Okay. But that is definitely part of the model. Definitely. Thank you.
Thank you.
Yeah. All right. So health promotion. Yes.
Hey, can I ask you a question? I'm just thinking about this sort of care coordination, 24/7 clinician availability for phone triage and support. What's the expectation of the team as you guys have drafted this in terms of whether the team is a consultative team or a treating team? I'll take it from the hypothetical into the real. It's 2 o'clock in the morning and a patient calls who's really dyspneic, who's got known severe congestive heart failure. Okay. That probably that person may have a primary care provider, may even have a cardiologist, may have a whole kind of dedicated medical team. Is it the responsibility of the palliative care team to intervene and provide symptomatic relief, or to make recommendations and coordinate the care? Those are actually two slightly different tasks. And I'm just not quite sure if I understand exactly what the role is, a direct treatment team, for want of a better term, versus a consultative role.
So how it's described is a 24/7 for triage, 24/7 coverage for triage and recommendation for, whether the patient needs to see the ER or, but it also may include the palliative care team should have access to the patient's EHR records and know the medications that the patient is taking. And so let's, for instance, if the patient needs to adjust the medication dose, or, there's so many different ways a patient could present, with complicated symptoms. If, in other words, there's some advice that can be given that would resolve the patient's concerns, and the patient is not determined to need to go to the ER, that type of advice would be expected, or as part of it, just that clinical triage of options that the patient has, and then of course if it is an emergency, absolutely directing the patient to access the emergency room. The palliative care team is intended to be this comprehensive care management team. It does not replace, with the exception of a few of the services that we've identified, like the one assessment in the home, medication reconciliation, and the 24/7 triage service. Other services, medical services, the patient needs outside of this model are just that. They're outside of this model. They're medical services the patient needs.
Thank you.
Mm-hmm. Any other questions?
Can I just, so Heather, it sounds like for the 24/7 support, it really is phone support. There's not an expectation that you can get into the home 24/7. Is that correct?
Yes, this is 24/7 phone support.
Okay.
That we're talking about in this draft. Yep.
Yep, that's what I did at the.
All right. Any other questions? Great questions. I appreciate them. Thank you. So health promotion is really about helping the patient with serious illness and their family understand how to develop like self-management skills, understand their illness, education regarding self-care management, health crisis management plan, advanced care planning, helping the patient contextualize health education and prognosis that's been provided with their individual needs, goals, and preferences, and the development of knowledge, skills, and protocols to reduce the risk of symptom exacerbation. And so it's about empowering the patient with education and protocol development to help them to manage their ongoing and progressive experience of serious illness, and to develop those skills both to mitigate, but also to know how to handle their symptoms and to prevent exacerbation when possible. Any questions? Okay. Comprehensive transitional care is, as it sounds, helping the patient, it's meant to reduce and prevent gaps when there's transitions within care settings, between care providers, and between settings of care in the patient's residence. So this is just when a patient, say, is released from the hospital and they have a discharge plan assisting the patient with access to making sure they have the follow-up appointments and their medications that they need, making sure they understand how to take those medications, doing a reconciliation post-discharge to make sure that there aren't any issues regarding those multiple prescriptions, care coordination, and patient navigation for all those follow-up, and also for durable medical equipment and supports and supplies that help them with their improve their quality of life at home. Any questions? Move on. And so, Jane, this is where I was talking about individual and family supports. So this is an approach that is intended to increase the patient, family, and caregiver knowledge about the patient's experience of serious illness. It is to provide supports in helping the patient and their family and their caregivers in handling the psychosocial stress associated with serious illness, the impact and it's the impact on the family and the patient, the family and guardians and caregivers, to understand disease progression and management strategies, to provide education, tools, and supports for patients of pediatric, for parents of pediatric patients with serious illness, and caregiver resources to address unmet needs through connection to covered services and supports, and education about community-based organization resources and services. So this is intended to really help the whole patient, the patient and the whole family understand the needs of the patient and how to best support that patient, and the needs of the stresses on the caregivers, and how to understand how to address that. Again, this connects with care coordination. So if it's identified that there's caregiver stress, then care coordination regarding available resources for in-home supports or long-term services and supports would be part of that. Any questions? Jane, I see you're off mute, so go right ahead.
So I still think this is a little bit different than the care navigation issue, because often the patient is so overwhelmed by their symptoms that it's a caregiver who's actually navigating a lot of their care, making their appointments, dealing with specialists, primary caregivers, similarly to parents with a child. So I would suggest that you still include a bullet in the care navigation to include caregivers to the extent that it's appropriate with care navigation, in addition to the supports that you have on this slide.
Okay, and that, so those kind of care navigation, care coordination supports. So you're talking about when the caregiver is the one doing that care coordination, correct?
Yes.
Yes.
Often you have a spouse or a daughter who is really handling a lot of the care navigation for the patient. So I just want you to make sure you cover it in your list.
Yes, absolutely. And so the care coordination services delivered by the team should be doing that for the patient. And so that should relieve that duty from the family, to the degree, not that the family would be disengaged, but the care coordination burden would fall on the team to do that. But absolutely, we'll take that into consideration to make sure that that language is clear around that, and that support is included. Any other thoughts, questions? Okay.
I have a
Oh, you do. I just saw you, Lauren. Go ahead.
Yeah, this is just really helpful seeing this all printed out like this. Thank you for preparing this. The one thing I'm not even sure if we've had conversations about it, and I don't know if it needs to be included here, but we really haven't addressed bereavement. I mean, theoretically, maybe most of these patients will be moved on to hospice where bereavement isn't an issue, but some patients will die in these programs, and I'm wondering if we ought to add bereavement as a concern or an opportunity to refer.
Yeah, I would. Yeah, and in this high level slides, psychosocial stress, I think bereavement would be part of that. If that's what the family is experiencing based upon the patient's current status. But absolutely, those supports and referrals can be made as part of this model.
Yeah, great. Thank you.
Any other questions? Okay. So the last service category is referrals to community and social support services. And it really is, what it says, based upon the patient's needs, whether they have health-related social needs, sometimes health-related social needs like transportation, financial, mobility can be issues with, accessing care. Just understanding the patient's needs and referring to community and social support service or community-based organizations that can address those needs, and having relationships with the CBOs in the communities that the provider serves is an important part of this model, to make sure that the patient has both community supports as well as the team supporting them, but also is connected with the community supports that they need based upon their plan of care goals. Any questions before we move on? Or thoughts? Okay. So patient eligibility, the draft patient eligibility that we've been working on is adults and children with main care eligibility and qualifying chronic conditions and who are experiencing serious illness with ongoing and progressive evidence of functional decline and or symptom exacerbation, or a child with a rare pediatric disease. And so this is, on a high level. So it's main care eligibility, chronic conditions, and then this experience of serious illness. The chronic condition, there's basically two steps. The first step is chronic condition eligibility, which is the individual has a diagnosis of 2 chronic conditions or has 1 chronic condition and a risk for another. And this in the box here is are examples of chronic conditions that we've identified would align with this model. Some obviously are, potentially lower acuity than serious illness, and that's why we have the second step, because of course someone could have heart disease and be a tobacco user but not have serious illness. And so let's move to the next step. And I put this slide in here just as a reminder that serious illness is a condition or multi-morbidity. It is a health condition or multi-morbidity that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life or excessively strains their caregivers. And I wanted to put that in here just as a reminder because this slide is heavy in details and we'll take some time with it. But it defines the next step of eligibility in this draft as the patient with serious illness meeting chronic condition eligibility. So the definition of serious illness, meeting chronic condition eligibility, and experiencing progressive and ongoing functional decline and or symptom exacerbation as evidenced by a minimum of 2 of the following criteria. And so then we have a list here of requires intensive treatment and intervention aimed at maintaining quality of life and or symptom stabilization, or is assessed as having at least 1 activity of daily living impairment, requires DME and or medical supplies for daily living or to treat the condition, requires polypharmacy to treat the condition and or manage symptoms, requires multiple high-risk medications, inpatient and emergency department utilization in the last 6 months aimed at treating and or mitigating the condition, is dependent on daily informal or formal caregiver supports. And the last one, a patient with a CMS, Centers for Medicare Services, hierarchical condition category risk score, HCC risk score of 3.0 with progressive and ongoing functional decline is evidenced by a minimum of 1 of the factors listed in A through G. So I'll pause there and let everyone kind of look at the slide. And do you have any questions or thoughts? Any feedback? And so this is the adult, and adults would be equal to or greater than 21 years.
I think my only sort of thing that I'd throw out, I'm curious what other palliative care clinicians think, is that you could imagine a patient with diabetes and hypertension with severe chronic back pain who is unable to function, qualifying based on these criteria. And that's not typically someone that most of our, at least as far as I know, most of our teams would see.
In that situation, would the patient though meet the serious illness definition of a high risk for mortality? Do you think, would you necessarily review it that way?
So they have to, maybe I missed that. So they have to have the 2 diagnoses, have a high risk of mortality, and have 2 of these things.
Yeah, so it's
okay.
So,
all right.
so they have, yeah, they have serious illness defined this way, which is why I kind of put the slide back in here.
I see. And either negative or excessively strains their caregivers. I think that somebody could argue that with somebody that, I mean, I just know because people are constantly trying to get our team to see these sorts of patients, that I could see a primary care clinician saying, this person's back pain or severe fibromyalgia or severe long COVID is excessively straining their caregiver and also doing these other things. So I don't know.
Yeah, it's
very hard to define serious illness, so I get that.
Yeah, and so our goal is in the project to date has been to create. Let me go back to the slide with the adults. Has been to create clinical prospective eligibility criteria, which means like that you can identify, you the provider, the clinician, could identify someone who is eligible in your interactions with them, and to provide that research-based criteria that identifies that population. And so there is this triage step-down way of identifying. I appreciate the feedback though around that or excessive caregiver strain, because I think that possibly is. At the same time, I think your clinical judgment around, is this a patient who is experiencing serious illness and needing palliative care team services, is a valid judgment call when you're reviewing a patient's, for clinical eligibility. So I think that clinical judgment would play a role in determining whether you're able to put that person on your panel or not. But at the same time,
oh, sorry, Heather, go ahead. I didn't mean to interrupt you.
No, at the same time, thanks for the feedback, because we'll keep, this is still a model in development. This is a draft at this point. And so we'll keep trying to we're really trying to make sure. What we don't want to do is exclude a whole host of people who really need the services. Right. And also, we would rather have earlier intervention. We obviously don't want to have intervention before it's really needed, but we'd rather see earlier intervention to help improve continuity of care and quality of life before you start getting to worse and worse symptom exacerbation and crisis care. So there's a delicate balance, but the feedback will help us to try to continue to target.
Yeah, I think that I agree, and I think all of us who are leaders in palliative care have struggled with this very topic of like, how do you define it? How do you explain it? Because even risk of mortality, people are like, well, diabetes does shorten life, So, but I think maybe whatever you guys end up developing in materials that goes to patients and families, of being clear about that clinical judgment piece, because I can imagine situations where people look at this and say, yeah, I qualify, when the reality is, like, if we in palliative care took every patient that met these criteria, we would quickly be overwhelmed, right? So.
Mm-hmm. Thank you. That's good. And we may be able to, again, as we're developing this draft, we may be able to incorporate some of that in the language of the draft to, ensure that we're supporting that clinical judgment. Lauren?
Yeah, I think this is tricky. I mean, this whole conversation that's been going on regarding this benefit, this part has been particularly challenging for me. And I think that your comments really, really sort of underlined that, Becca. I mean, I think you have a program and you know what your criteria for taking care of patients would be. This is a patient that we can take care of based on our own criteria. Is that the same thing as saying this person qualifies for your program because main care covers it? And I don't think they do. I think you've got your program, you know what you can manage. I think, correct me if I'm wrong, Heather, I think, the goal is not to make this payer eliminate people. It's meant to be a little bit more inclusive, I think, such that a barrier to payment should not be a barrier to access to services. So does that make sense?
Yeah. The goal is to provide. Oh, go ahead, Becca. I'm sorry.
No, I was just saying, you're saying you want it to be very sensitive, not that specific, and let the program sort of bring the specificity kind of to the criteria.
And I think it deserves
a balance.
And you know, Heather, too, I think, you know, the beautiful work that you've done here is that you've taken an existing piece of policy and you're trying to sort of maintain the requirements for that policy to make it legitimate and correct while while fitting in the requirements for palliative care such that new policies created, but not from the ground up. So
yeah. The only thing that I would just sort of throw out there for your consideration is that if at the end of the day, we are going to want to show that this benefit ultimately is financially sustainable, right? So saves money, provides benefit for the money that Maine Care is paying. And if you look at some of the recent data around having home-based palliative care programs that are more inclusive, it's actually harder to show that benefit. So I think that's sort of like the balance, right? Around also that also should be thought about as we're, constructing this. But anyway, I hear what you're saying, Lauren. I think that makes sense.
And I think when we get to the slide after the children's eligibility criteria, we've established in this draft discharge criteria, which I think helps to balance out some of that concern as well. But thank you for the feedback, because we are going to continue, because yes, we would rather err on the side of patients getting services at the first point they need it, rather than waiting until they're needing to utilize crisis care and they're experiencing hardship and trauma related to their serious illness, rather than having earlier intervention for continuity of care and care management services. But at the same time, that doesn't mean that we also want to balance that with not opening the door to individuals who don't need this level of care. And I think the discharge criteria may help to provide some balance. And so we'll review that in a moment. And so, go ahead.
Heather, I'm sorry, can I ask one?
Yeah.
What do we anticipate Maine Care's role, if any, in identifying patients for the program? Meaning, like, you guys have a huge amount of claims-based database. You understand actually people who qualify for some of this. The community care team, concept, for instance, has undergone several iterations where at one point, trying to point teams in the direction of serving people who kind of qualified and needed the help. And I'm just like, is this a passive approach by Maine Care, and it's up to the provider networks to find the appropriate patients and fit them in along the qualifications that they might define within the population of patients who would qualify for Maine Care?
I'd say at this point, we're still developing the parameters. And I think that's going to be a conversation that we will be addressing in our future, because we'll be having several stakeholder meetings to try to start discussing some of the areas in more detail. So I'd say basically at this point, I'm not exactly sure what the plan would be as far as maybe, identifying patients and claims that the department feels are eligible. But I would say that the intention of the eligibility criteria as drafted today is to empower providers to be able to identify patients, because a patient who is presenting in the office with those complications, if there's clear criteria and that the patient needs it, we would want those opportunities to be able to be utilized to get that patient connected with the services. So in other words, empowering our palliative care program providers to understand these parameters so that they can make referrals, which is part of that program as well, to make referrals to palliative care for patients that meet the eligibility criteria. Obviously, this is not developed yet, but that is part of the model that exists now. So this is a work in progress, but we'll definitely circle back to that and develop that more.
Yeah, and Heather, I'll jump in to this, Olivia from Maine Care. Just for everyone, I think one of the things Vance is talking about is in our community care team model today, providers they have the ability to essentially look up members that they are potentially going to provide services to and see some key indicators about their hospital admissions, or, I mean, in this case, you know, do they receive a DME? Are they receiving DME or other things like that? So I think it's a great, it's a great thing to get to in the future is when the criteria is set, what information do we hold that we can share and how? I mean, there's different mechanisms for sharing information. Risk scores, for example, is one. Like, you know, what if you're not using that type of risk score, but we have a version of the risk score. So I think that's a great thing for providers to think about. What of this information do you have, not just obviously by talking to the individual, but, you know, have access to, and what do you think we have access to, and we can come together around what we can share.
Yeah. The other question, I apologize for asking so many of these, but the other question, I guess, is since this is sort of episodic based longitudinal payment, when does an episode of care start? I'm just, you know, this sort of seems like in an ideal world, we'd find these people and they're going to start, you know, getting in the care of a community-based care team. The reality that I think we're going to encounter is a huge number of these people end up with initial palliative consultation in an acute care setting, period. End of story. That no matter how we try that, there are going to be crises that are going to inspire, and the patient's really going to come to attention with serious, you know, illness and qualify for that. Do we anticipate, for want of a better term, if somebody from a inpatient palliative care team sees a patient consultation, that the episode of care and longitudinal based payment starts then?
So in these models, these models require patient consent, and so usually the ability to add a member to a panel begins with that consent. And so at whatever point that consent happens, and if it is a per member per month, you know, if it's a calendar month, or as you know, with CCTs, an attestation month, then there's some payment wherever if the service happened in the middle of that monthly period, right, there's payment for time before that if there was outreach to the patient or engagement with the patient done prior to that. And so that's where the flexibility of an APM model helps to reimburse for that kind of patient engagement. But typically the panel and billing begins with patient consent.
Thank you.
Mm-hmm. Go ahead, Lauren.
Well, just to clarify that question. So I think what you're asking, Vance, if a palliative care clinician, palliative care team sees a patient in the hospital and then discharges the patient into the community, into a home-based palliative care program, where does that start? Is it upon the first day after discharge, or the day of discharge, or does it start with the first day of the consult in the hospital? Is that what your question is?
Yeah, that's in essence the question. And, you know, if the patient, and I guess a subset of the question is, are we going to end up paying that palliative provider sees a patient in the hospital setting out of this, you know, benefit, or is it going to be a separate carve out for, you know, typical, you know, kind of Part B type, you know, payment overall for services in that setting? I might argue, I'm all in favor of the payment model you're providing, but I might say that maybe we're going to have to end up, from an administrative perspective, paying for hospital-based services differently than in this model. You know, I can imagine patients we end up seeing in a community hospital setting in Lewiston may end up at Maine Med, you know, one way or the other, and need the acute care services, you know, model of palliative services provided there to derive maximum benefit for their well-being. So, you know, and it's kind of hard when you start paying people on a population-based longitudinal model to figure out, for want of a better term, how that stuff gets adjudicated in between organizations.
Mm-hmm. So the hospital-based consultation, you're talking about like a hospitalist or, you know, whomever provides that consult in the hospital.
I think he's saying that, like, say a patient's on Androscoggin, home-based palliative care, gets admitted to Maine Medical Center and sees the Maine Health or Maine Medical Center palliative care team. Is his organization responsible for paying our palliative care team for our services, or is it that we would bill just like we do now for inpatients, which I think is what you're saying.
Yeah, well, that's part of the question. Yeah, sure.
Yeah, thank you for that clarification. So the palliative care team is an outpatient community-based service. Hospital-based palliative care, when it's like a consult related to what the patient is, that's currently billed, I'm assuming, either under professional services or with under the patient's diagnosis related group billing. Those would be two separate things. But I think we definitely should make this a topic of conversation, or include this for future model. We haven't yet even begun to think about even begun to talk about like how we're going to configure this in our claim system and all of that. But this model is intended to be providing that care coordination across all settings. And so if the patient is in the hospital and is on your panel, the intent is that you would follow the patient to that setting. That doesn't mean that they wouldn't necessarily be receiving discharge like you would be engaging with the discharge planning, which may include a palliative care assessment from the hospital if that's part of the patient's needs at that time. But again, this is like part and pieces of that we haven't really worked through, but we definitely will be. So let's definitely bring that back around.
And I just want to clarify too that I think, Heather, I mean, Part B billing for physician and nurse practitioner services are outside of this. Is that right?
Yeah. Yes, except for the few services that we've identified that are services, for instance, the inpatient assessment that the one annual would be paid for as part of the bundle as this model is drafted out. But additional in-home assessments would be billed fee for service, or part of Medicare Advantage, depending on what the patient's coverage is.
Yeah.
If we're talking about dually eligible. Becca, you had your hand up.
Well, I was just going to say, I mean, it's going to be hard to expect community-based teams to be providing care in the inpatient setting if they're not credentialed in that place, right? Which they're not necessarily going to be credentialed in all of the hospitals.
Yeah, I think. Oh, go ahead.
Oh, I think you just might have misspoke, Heather. You said inpatient, but you meant in-home.
In-home.
In-home, and I just meant the care coordination piece, like coordinating with the discharge staff
at the time
for
of
that transition, right? For the transitional care, reach as far as inpatient goes, not
coming into the hospital. Yeah. Okay.
Yeah, not doing a clinical assessment in the hospital of the patient, because yes, that gets into the need to have credentials for the hospital and all of that. I mean the care coordination piece for the transitional care management, and engaging with discharge. Yeah. But again, there are pieces of this that we will need to readdress and discuss, and we will definitely bring this back around for further discussion. Vanessa?
I was just going to add, as part of these conversations about the consultation versus the intensity of this team and eligibility, that I kind of see it as some people are getting still the fee for service consults that aren't necessarily doing this whole main care, high intensity palliative care.
Right. Yes. And that one is like a fee for service billed occurrence, like an E&M, but it's palliative care consultation focused, where this is a whole team providing that care coordination and supports and everything. And there will need to be configuration and clarification around the billing guidance and development for that. So we'll definitely return to that and review that. So the slide for children's eligibility has been up for a bit. It mirrors the adult with some of the aspects, of course, being, fitting a child's experience. Any questions about that? I want to make sure we have time to review the staffing survey pieces. All right. So let's move to the staffing survey pieces. And like I said, I'll be sending out the staffing survey after the meeting. And so it has much more detail. And so I encourage you to really review it. in detail because it's going to really support you in being able to complete the survey accurately. So discharge criteria is the expectation that patients are reviewed for eligibility, for continued eligibility, and for the appropriateness of palliative care team services. Are palliative care team services still appropriate? And so one way that we would identify patients for whom maybe they're ready for discharge from a palliative care team is that they've met their goals of care as defined in their current plan of care, and they've established stabilization in their ongoing and progressive experience of serious illness, which are those elements for eligibility. And they've required over the last 3 months no more than one covered service monthly over 3 months. And that could have been delivered as a single E&M. So when you get to, if a patient, say, for instance, someone who had cancer, they're in remission, and they've really not needed intensive services, and you've had maybe a consult, a nurse management consult with that patient, once a month, and that really could have been in a monthly E&M visit, then that would be a situation where it would be time to start thinking about if that patient is eligible for discharge, no longer if palliative care team services are no longer appropriate. And I hope that kind of discharge criteria helps to balance out that concern about under acuity of the panel and when it would be appropriate for discharge. And of course, obviously, if the patient has opted for a service model that is a duplication of palliative care team services, then they would also be eligible for discharge in this draft. Any thoughts? Go ahead, Jane.
I guess once again, I would encourage involving caregivers before you discharge somebody, because it's always possible the patient thinks they don't need anything and the caregiver thinks otherwise.
Yeah, and hopefully that's captured in the plan of care part, because the plan of care is intended to capture the experience of the patient within their family and their caregiver supports. And so hopefully if they're meeting that, that's part of that. But thank you. Yeah, that's ensure that the language is clear as we move forward. Any other thoughts or concerns? Okay. All right, so the staffing survey guidelines. All right, so here's the 4 parts of the staffing survey: provider info and payer mix. So just, who are you? What is your organization? That kind of thing. We'll cover that. Your payer mix for these services, team distribution of service delivery, monthly episodes of care, and staffing ratios. Those are the parts. We're going to review them in detail. And we're asking that these surveys be returned to me by May 1st, and my email is linked in there. And so let's review the piece. These are surveys that are going to help us in understanding the next steps for this project in continuing to define the model. And so the first part is or provider or organization name, NPI or NPI +3 as enrolled in main care, address, contact phone number, name, and professional role of the person completing the survey, and then the payer mix for palliative care services. So if you currently have, this may be either actually what you're doing if you have a community-based palliative care program, or it may be what you project it would be based upon patients that you have on your current palliative care panel that you would consider eligible for a model like this. And so this is a guesstimate, as best as you can ascertain from the data that you have what your percentage of payer mix would be. We are working with NASHP. I will just clarify, and they are providing actuarial and data analytics supports to help us to, build out fiscal projections and things like that to help us in support of building the model. So this is part of understanding dual eligible claims and all of that. And so then this is asking for the team distribution of service delivery for adult services. So across your team, which is up at the top, clinical leader, behavioral health clinician, nurse care manager, pharmacist, and clinical chaplain. For the services or service categories, who is delivering, what percent? So the clinical leader is delivering of the service categories, what percent, the 24/7, what percent, and then each row should equal 100%. And that just helps us to understand the distribution across the roles of the team. And you'll notice that the medical director and manager are not on this chart, and that is because they're not delivering direct services. So their role would be factored in otherwise. Any questions on this before I move to the children's? Okay. And so this is the same here for children in the same exercise. Of course, this chart includes the child life specialist. And so the next is episodes in minutes. So as you imagine, in fee for service, you have an E&M, how long, evaluation and management visit, how long that is. In a team-based care model, those episodes of care are not necessarily an hour or a half an hour. And so what we were asking for is how many episodes in a month and how many total minutes in a month, to help us understand per role how many episodes per month and how many total minutes, so that we can begin to develop out some averages and expectations. Any questions? Pause here. I don't want to get ahead of anyone. Okay. And so the next staffing survey piece here is the staffing ratios. So per FTE, and again, this model as drafted, does not require each role to be a full FTE, but we would like to understand how many patients could be served by one full-time equivalent employee. So per each role. And then, we've given throughout the survey places to put notes where you feel maybe there's additional staffing person that should be included, or clarifications on what you've reported, anything like that. Feel free to provide those notes. And so that is really it for the survey. And the survey model, the survey draft will also include, like I said, a lot more detail on the draft palliative care team services model that we've developed. And so I recommend that you really read through that and before you fill it out, to best be able to think about length of stay, discharge planning, but also, care coordination, all those different categories and all of the different services under them that roll up under those categories, and the time that would be spent by the different team members to deliver those services to support individuals in meeting their plan of care goals. And so what are our next steps in this project? So this, we have support from NASHP over the next 2 months, and they'll be working with cost and utilization analysis with us. And this staffing survey will help us to support that work. We're going to be doing continued stakeholder collaboration to talk about some of these issues that we've identified today, and I'm sure other issues that we'll identify, to get clarification on those pieces and make sure that the final model that goes to policy drafting will be clear. We'll be reviewing aspects with CMS to ensure that we can get approval, and then OMS policy drafting will begin. There'll be a public rate forum during that period that will present the rates, the draft rates, and allow a time for a public comment period. And then the rulemaking will begin, and rulemaking will also include a public comment period. And we will then also be working towards CMS approval in this process. And so those are the next steps in moving forward in reviewing, getting this model to a final place. Any questions?
I have a question.
Yeah.
Go ahead.
Oh, Natalia, go ahead.
I'm sorry, I was trying to find the raise my hand button and I just was too slow. So Heather, just a couple questions I had real quick. The first one is on the survey. When you're asking the question about number of patients that could be served per FTE, in what time frame? Is that outlined?
It's like a patient panel.
Okay.
And so on your average patient panel, how many patients per, say, clinical lead would you need to have, how many patients would one full-time equivalent, before you would need to add an additional clinical provider? It's the same thing for each other role.
Okay, got it, thank you.
And that's what, oh, go ahead.
I'm sorry. And then the other question I had was, is this program really being designed for community or outpatient palliative care primarily?
Yes.
Okay, that's what I thought, but I didn't want to assume. Thank you. Did you have a different question, Dr. Little, or something?
Okay. Any other questions or feedback? Go ahead, Candace. I think you're still muted. I can try to unmute you.
What do you anticipate as the time frame to completion?
That at this point is honestly difficult to say, partially because different pieces of it are so far out. At that point we'll know, you know what I mean? Like, so in other words, I think in the fall we'll have a better idea of when you know, the public rate forum might occur. You know, as we move forward, we'll have better ideas. It's hard at this point of the project to point to a particular date, but we will be progressing along these steps.
Oh, sure. I just wondered if it would be another year and a half. I wasn't looking for a date. I was just looking for a time frame. Yeah.
Yeah, I would say we're aiming for the next year and a half. But if we'd love it to be sooner, but again, some of these pieces, negotiation with CMS can take a while sometimes, working through rule promulgation can take a while. Some of those pieces are harder to nail down, but.
Right. I just don't want to give false information. My colleagues have been asking out of, other colleagues in other states, and I don't want to give them incorrect information. So,
and that's kind of my concern, is I don't want to give you incorrect information for the pieces that aren't as predictable as we'd like them to be. So
sure. Thanks though for guessing. Yeah, thanks.
Go ahead, Vanessa.
I just wanted to clarify one thing, because I think some of us that have programs don't have all of those items that are listed on the staff survey. We don't have all those disciplines necessarily. And maybe you said this, but I just want to bring attention to it. It doesn't have to be like all within the palliative care payroll. It could be a less formal relationship with some of the disciplines.
Yes. I mean, you would have some sort of relationship with let's just say, you have a clinical team and you have a relationship with, say, the behavioral health professional, and they deliver the services as they're needed based upon the patient's plan of care. But they're not necessarily an employee of the palliative care team. Is that what you're saying?
Yeah, or like you have a pharmacist that works in your organization.
Yes.
But they are not like specifically a palliative care pharmacist.
Yes, you have someone that will deliver that medication reconciliation, but they're not on your palliative care team. They're not part of your payroll, like you said.
Well, could it be that the medication reconciliation is happening by the nurses and that you have a pharmacist available for particular questions about drug interactions or something?
Yes.
Okay.
I think part of what, and you'll probably have more questions as you fill out the survey, and part of the process is just asking the question. So we'd rather you ask the question so the survey can be filled out in a way that we both are interpreting it the same way. But part of what it I think is good is if you put true information, like what is your current model look like? So like if you're, you know, the amount of time you're a pharmacist, some programs have pharmacist involvement is much lower than others. That's good for us to know. So then we can, when we're processing it to set rates, we can go back and ask more questions about that. And then again, we define the model based on what we think is appropriate to pay. And then still we pay a rate and there's some minimum expectations, but the providers still get to meet the requirements however they see fit. So just, I would say like answer the questions as you're currently situated within your programs, as your programs currently operate. Because we'll notice if your program looks very different than another program, and we'll ask you about that.
Yep. Go ahead, Vance.
Sorry, I still hadn't figured out where the raise your hand button.
No worries.
Let's see. I just want to go back to one of the other issues related to kind of qualification. Most services ultimately end up being provided under the, if I use the term, under an order from a referring provider. You know, that's the way hospice services work, the way a lot of other services work. If a patient qualifies, or we actually ultimately figure out in the end of the day who's identifying those patients, are we going to need to be able to provide those services, need to cycle back to a referring clinician, or are we going to have, for want of a better term, authorization to go ahead and proceed and deliver the services?
The model doesn't require referral. The model is drafted right now, does not require referral. And so if the patient can have referral, but they're not required, the referral is not at this point required. And so, yes, you could prospectively identify patients who are eligible and for those services as it's drafted now. Is that answering your question?
Yeah, absolutely. Thank you.
Mm-hmm. Any other questions?
Well, I just want to take the opportunity to highlight that on this end doesn't require a referral, but many of you know that we are trying in our Primary Care Plus program, we are requiring that the primary care practices, which is over 220 practices, are able to make referrals to palliative care services. So we expect that there will be referrals, hopefully more referrals once we get through some more education and kind of what that means and what that can look like. But it wouldn't be part of what allows you to deliver services.
Yeah, no, I think obviously it's in an ideal world, it's great if one gets a referral and that sort of sets up a collaborative relationship, which this work is all about. So that's preferable. On the other hand, there are times where, the patient really needs services and, it requires an amazing amount of energy to actually break through the iron curtain of a primary care provider's office these days. Be able to actually get, referrals in a timely fashion, established, and so forth. And obviously in some domains that's, starting care, it's essentially illegal or you got a compliance problem to do it. And others, and the way you guys have drafted this, doesn't sound like that's an issue. So.
Thanks for that feedback, because that, gives me ideas about possible future collaborative, technical support, advisory support we can provide, to help primary care, PC Plus teams, PC Plus providers, and other providers understand what is a palliative care benefit and the model, and hope to start to break down some of those barriers. Well, thank you. I cannot tell you how much I've appreciated your collaboration over the last 2 years in building this model. You are really an amazing team of collaborators and partners in this, and we will continue to engage over the next few months as we work on some of these areas that we identified today and to refine this model. So I want to thank you personally and appreciate your time. I will be sending out that staffing survey by email after this meeting, and we've got your email addresses in the chat. If you do have any additional questions, you can feel free to reach out to me by email. I'd be happy to address any additional questions. Vanessa, I saw your hand up.
That was just me clapping for you because you did a great
Oh.
job presenting a very complicated process and 2 years of work in a very straightforward way. And thank you.
Thank you. I appreciate that. Thank you. Thank you so much. Well, thank you, everyone. I appreciate your time. I'm very excited about this, and we'll move forward together. Thank you. Bye-bye.
Good job, Heather.
Oh, thank you, Lisa. Appreciate it. Thank you. Hey, Amanda, can you hang on for a minute?
Yep, I'm just like,
Were you able to get everybody?
yep.
You are awesome. I just look, you have to take the worship when you get it.
No, I'm gonna worship you because that was like the most relaxed and comfortable forum I've ever been to.
Oh, good.
Like it was just so nice. I don't know. There was no confusion.
Good.
Everybody just had it was like a normal discussion. It was really nice.
This provider group and partners group, stakeholder group has been